Chapter 6 and 14, Vital Signs and Oxygen Administration and Caring for the Patients Needing Alternative Medical Treatments. Measuring vital signs. Taking a patient's vital signs, also called cardinal signs, is an important part of the physical assessment and includes body temperature, pulse, respiration, and blood pressure. AKA, again, vital signs is called cardinal signs. Vital signs in the imaging department. When the patient's general condition changes or if the patient reports nonspecific symptoms, such as simply as not feeling well, RN is not available, prior to an invasive procedure, or before and after administration of meds. Body temperature. Body temperature is the physiological balance between heat produced in the body tissue and heat lost to the environment. It is controlled by a small structure in the basal region of the brain called the hypothalamus. Changes in body's physiology occur when the body temperature fluctuates 2 to 3 degrees. Factors that can cause a change in the body temperature: the environment, time of day, age, weight, hormone levels, physical activity, disease, and injury. Normal body temperatures for an adult 14 and over, 97.8 to 99, child 5 to 13, 97.8 to 98.6, infant 3 months to 3 years, 99.0 to 99.7. A patient whose body temperature is elevated above normal limits is called to have a fever, aka pyrexia. So again, pyrexia means fever. Fever indicates a disturbance in the heat regulating centers of the body, usually due to the disease process. As the body temperature increases, the body demands for more oxygen increases. If a person's body temperature is below normal limits, they are said to have hypothermia. Hypothermia may be induced medically to reduce a patient's need for oxygen. A person can die without temperatures above 105.8 to 111.2 or below 93.2 degrees. Measuring body temperature. 4 areas of the body to measure temperature: mouth, oral, under the tongue, normal is 98.6, ear, tympanic, 97.6, rectum, anal opening, 99.6, armpit, which we know as axillary, is 97.6 to 98. A tympanic membrane thermometer, also called the auroral thermometer, small handheld device that places the probe close to the tympanic membrane that provides a reading close to the core body temperature. The electronic and glass thermometer for oral temperature. This method is the same as auroral, except that the probe is longer and is placed in the mouth under the tongue and held in place until a digital reading is produced. The glass thermometer should not be used if the patient is apt to be injured during the procedure by biting down, or if the patient is unable to keep the mouth and lips closed for 3 to 5 minutes. Axillary temperature. The use of axillary sight is the safest method because it is non-invasive. An electronic or glass thermometer may be used. Time and precision placement are needed to obtain an accurate reading. Rectal temperature. This site is considered to provide the most reliable measurement of the body temperature. It is also in close proximity to the pelvic region or core temperature of the body. This method should not be used if patients are restless or has rectal bleeding or hemorrhoids. Use the thermometer with a blunt tip. Temporal temperature. Temporal is on the temple and is instant. TA thermometry, accurate and easy. It's a swipe the forehead for the measurement with a probe or sheath. Pulse. As the pulse beats, blood is pumped into the arteries. This results in a throb or pulsating of the artery that is felt by a superficial skin. At the areas of the body in which arteries are superficial, the pulse can be felt by holding the artery beneath the skin against a solid surface, such as bone. 9 locations to measure a pulse. Apical can be heard with a stethoscope. Radial at the wrist at the base of the thumb. Carotid at the neck. Femoral at the groin. Popliteal is post-knee. Temporal is front of the ear. Dorsalis medius is top of the foot. Posttibial inner side of the ankle or brachial groove of the elbow. Average pulse rates. Adult is 60 to 90 beats per minute. Child is 90 to 100 beats per minute. Infant is 100 beats per minute. Assessment of pulse. The pulse rate is a rapid and relatively efficient means of assessing cardiovascular function. Tachy always means above, brady always means below. So tachycardia is an abnormally rapid Heart rate, over 100 beats per minute. Bradycardia is an abnormally slow heart rate, below 60 beats per minute. The radial pulse is usually the most accessible and can be taken most conveniently on any adult. When taking a pulse, be careful not to press too hard with fingers. Do not use the thumb to count the pulse because it has its own pulse. Have a watch with second hand to count for 1 full minute. Respiration. The function of the respiratory system is to exchange oxygen and carbon dioxide between the external environment and the blood circulating in the body. Oxygen is taken into the lungs during the inspiration. It passes through the bronchi, into the bronchioles, and into the alveoli, which are the gas exchange units of the lungs. Oxygen is transported to the body tissues by the arterial blood. This is a diagram depicting inhalation and exhalation. Respiratory average baselines. Adult is 15 to 20 breaths per minute. A child 1 to 10 is 20 to 30 breaths per minute. An infant under 1 is 30 to 60. Respiration should be quiet, effortless, and uniform. Assessment of respiration. The patient is in present position. Observe the wall. For symmetry of movement, observe the skin color, such as cyanosis. Count the number of times the patient's chest rises and falls in 1 full minute. The patient should not be aware that respirations are being counted because it may alter their normal pattern. Respirations of fewer than 10 breaths per minute may change cyanosis, apprehension, restlessness, change in level of consciousness because the supply of oxygen is inadequate to meet the needs of the body, dyspnea when a patient is using more than the normal effort to breathe. Blood pressure. It is the amount of resistance the blood flow ejected from the left ventricle of the heart during systole and the amount of resistance of the blood meets due to systematic vascular resistance. The number of red blood cells in the blood plasma determines the viscosity of the blood. With an increased number, the blood thickens or becomes more viscous and subsequently increases the blood pressure. Maintenance of blood pressure depends on peripheral resistance, pumping action of the heart, blood volume, blood viscosity, elasticity of the vessel wall. Other factors that change blood pressure: age, weight, temperature, disease, and exercise, and stress. Normal blood pressure range: adult 90 to 120 systolic and 50/70 diastolic. Child 110 to 120 systolic, 70 to 80 diastolic. Adolescent 85 to 130 systolic, 45 to 85 diastolic. Baseline body pressure. Hyper again means above, so hypertensive. Systolic blood pressure is constantly over 140. Diastolic blood pressure is consistently over 90. Hypotensive is systolic blood pressure is less than 90. Blood pressure equipment. Sphygmomanometer is a blood pressure cuff. There are 2 types of sphygmomanometers: mercury manometer, which is the most accurate, or aneroid manometer. Stethoscope is an instrument used to listen. Blood pressure cuff should be selected according to your patient's size. Stethoscope includes a bladder, a bell, a plastic or rubber tubing, and earpieces. Reading blood pressure. First number is your systolic pressure, the highest point reached during contraction of the left ventricle of the heart as it pumps blood into the aorta. The second number is the diastolic pressure, the lowest point to which the pressure drops during relaxation of the ventricles. Measuring blood pressure. Patients should be sitting upright with arm inclined and supported. Sleeves should be rolled up, not too tight, around the arm. Room should be quiet to facilitate hearing the pulse. The bladder, bell, and earpieces should be cleansed with alcohol before and after each use. This is an example of blood pressure reading. Oxygen administration. An adequate oxygen supply is essential to life, and when a human being's oxygen supply is suddenly interrupted or interfered with, it is an emergency that needs immediate attention. It is your responsibility to ensure that the room you are assigned to has a full supply of oxygen and delivery method. The overall goal of oxygen therapy is to maintain adequate tissue oxygenation while minimizing cardiopulmonary work. Hypoxemia, when the level of oxygen in the arterial blood becomes inadequate to meet the patient's physiological needs. Pulse oximetry, used to monitor the oxygen saturation in the hemoglobin. This is a fast, non-invasive method of monitoring the patient for sudden changes in oxygen saturation. Normal SaO2 values are 95 to 100%. Values of less than 85% indicate that tissues are not receiving adequate oxygen. Hazard of oxygen administration. Oxygen is considered to be a medication, and like all other forms of therapy, it must be prescribed by a physician. Severe oxygen toxicity may cause irreversible damage. COPD, or chronic obstruction pulmonary disease, is excessive amounts of oxygen to patients who have COPD may depress the respiratory drive, and the patient may stop breathing. Infection and bacteria thrive on oxygenated areas. Therefore, the equipment used for oxygen must be replaced after each use. Oxygen is combustible, so take great care to prevent sparks from being near electrical equipment. Smoking is prohibited in rooms where oxygen is in use, and patients should not be around oxygen. High flow rates of oxygen are toxic to patients who have COPD because their respiration is controlled by higher levels of carbon dioxide in the blood. Oxygen delivery systems, the nasal cannula, the nasal catheter, and the face mask. This is an example of the nasal cannula, and this is a face mask. Other systems, transtracheal, mechanical ventilators, oxygen tent, home oxygen delivery system, oxygen delivery equipment for the imaging department. These are examples of those things that we just discussed. Introduction: nasogastric, NG tube, nasoenteric, NE tube, suction, tracheostomy tube, mechanical ventilation, chest tubes, Tisch drain tube, or endotracheal tube. Nasogastric tube, NG. This tube is inserted through the nasopharynx into the stomach, the duodenum, or the jejunum, made of polyurethane, silicone, or rubber. The NG tube contains a radiopaque tip to allow its visualization on images in fluoro. A radiograph will be obtained to verify correct placement. What is the purpose of the NG tube? To keep the stomach free of gastric contents and air, for healing purposes before or after surgery, for diagnostic examinations, administration of meds, feeding, treat intestinal obstruction, and control bleeding. Nasoenteric tubes, or NE. This tube passes in the duodenum and small intestine by means of peristalsis, made up of the same material as an NG tube, decompresses the intestine. Types of NG tubes: Levin and the Sum, which is the most common, Nutraflex, Moss, Singstaxton, Blackamore, esophageal tube. Refer to Table 13-1 for details. Types of NE tubes: Cantor, relieves obstruction in small intestines. Harris, gastric and intestinal decompression. Miller-Abbott, for decompression. Refer to Table 13-2 for details. Again, this is an important aspect to know which type of tube does what. These are examples of your different types of feeding tubes. Radiographers are not responsible for inserting or removing NG or NE tubes. Procedure is done by a registered nurse or physician. An initial radiograph is obtained to verify to physician. Transferring a patient with a nasogastric suction. On many occasions, the NG-NE tube may be hooked up to a suction apparatus that is either portable or available into the room for a central hospital unit. The suction can be intermittent or continuous. Check with patient's nurse prior to transferring the patient. Make sure to place the correct suction pressure when transferring the patient. Never clamp a double lumen NG tube because this may destroy the effect. The patient with a gastrostomy tube. A gastrostomy is a surgical creation of an opening into the stomach. Through this opening, a tube is placed from the inside of the stomach to the external abdominal wall for the purpose of feeding a patient who cannot tolerate oral food intake. The tube is closed off after feeding with a clamp or a plug-in adapter to prevent leakage of gastric fluid or food. The patient may be grieving, owing to the change in his or her body image or because of a chronic illness. These are examples of the gastrostomy tube. The patient with a central venous catheter. Central venous catheters are used for long-term medications, frequent blood transfusions, hyperosmolar solutions, or total parenteral nutrition. You must be aware of their presence and purpose and be familiar with the precautions when in place. When a patient does not have an adequate nutritional intake and cannot tolerate nourishment by means of the GI tract, he or she may be ordered to receive partial or total nutrition by an intravenous route. Partial parenteral is used when the patient is able to supply a part of his or her nutritional requirements by natural means. Partial supplementation, given through a large peripheral vein. Parenteral solution is diluted. Total parenteral, TPN, When the patient requires total nutritional support by parenteral method, it is delivered through a central vein of the central venous. TPN solutions are hyperosmotic. Highly concentrated could damage the intima, which is also the lining of the peripheral vein. This is a diagram demonstrating the different types of tubes discussed. CVP and PICC lines. CVP are used for measuring central nervous pressure and for nutrition. Best location for CVP is at the junction of the superior vena cava or within the SVD. PICC, a type of periphery, inserted central line, inserted into patient's arm and advanced until tip lies in a central vein at the junction of the right atrium of the superior vena cava. So again, it's important to know the difference between CVP and PICC lines and where they lie. A chest radiograph is obtained for correct placement. Technical factors are crucial for quality visualization. These are showing you some examples of both the CVP and the PICC lines. Emergency suctioning, profuse vomiting and patient unable to move voluntarily. Audible rattlings or gurgling sounds coming from the patient's throat. Signs of respiratory distress. Suctioning is an emergency procedure and not within your scope of practice. You may be asked to assist. Be familiar with the equipment and make sure it functions. Items necessary for suctioning: a wall outlet or working portable suction machine, adapters for wall outlets, clean gloves, and tubing. The patient with a tracheostomy. A tracheostomy is an opening into the trachea created surgically to relieve respiratory distress caused by an obstruction. It can be temporary or permanent. Constant suctioning due to the secretion buildup. Patients with newly inserted tracheostomy tubes are very fearful. Prior to imaging a patient with a tracheostomy, the radiographer should speak with the patient's nurse for any special considerations. The radiographer must take special care when moving the patient to avoid dislodgement. The tracheostomy tube must not be removed, and the tapes holding it in place must not be untied for any reason. These are examples of tracheostomy tubes. Mechanical ventilator. A patient who cannot breathe spontaneously or whose respiration is inadequate to oxygenate the blood are candidates for mechanical ventilation. Because mechanical ventilators support life, it is very important that you understand that precautions you must take when caring for a patient in this situation. Ask for assistance when doing portable radiography to avoid dislodgement. Two types of mechanical ventilators: negative pressure, seen most often in the home, and positive pressure, which is the most commonly used type. There are three categories: pressure cycled, time cycled, and volume cycled. Endotracheal tubes, or ET. This is a tube inserted through the mouth into the trachea as a means of establishing or opening an airway on patients. Correct placement of the tube is approximately 5 to 7 centimeters above the tracheal bifurcation, also known as carina or carina. These are examples of your ET tubes. A chest x-ray should always be taken after intubation to confirm proper placement of the tube. 20% of the ET tubes require repositioning. If the tube is too low, it usually enters the right bronchus, therefore causing a collapse of the left lung. If the tube is too high, it may cause air to enter the stomach and cause regurgitation of gastric contents, causing possible aspiration pneumonia. The patient with a chest tube and water-sealed drainage. When a lung is collapsed either by air or fluid, a chest tube is inserted to treat this condition. Pneumothorax is one of those conditions. It's where air enters the pleural cavity, causing the lung to collapse. Hemothorax is a collection of blood or fluid in the pleural cavity that prevents expansion of the lungs. Pleural effusion, fluid buildup in the pleural cavity. You must ascertain whether the patient has a chest tube before moving him or her and placing the IR. These tubes are often hidden under the blankets. A water-sealed drainage system is established by connecting the chest tube that originates in the pleural cavity to a clear tube that ends in the chamber containing sterile water or sterile normal saline solutions. The tube leading from the chest tube remains below water levels at all times to maintain the seal. This is an example of both the endotracheal and the chest tube. These are examples of the pathologies. Tissue drains. These drains are placed at or near wound sites or operative sites when large amounts of drainage are expected. The Penrose drain, the Jackson-Pratt drain, Hemovac, and Constavac Stryker. You must have special care of the patient when performing any type of exam. These drains can easily be dislodged and cause infection. These are examples of the different types of drains that we just previously discussed. The end.